While being called upon for resuscitation, we frequently encounter scenarios in which mothers have certain infections and thereby the infant is at high risk of acquisition. In this video, I shall be discussing 3 such scenarios, including perinatal HIV, maternal hepatitis B infection, and maternal tuberculosis. But before that, I would like to take a moment to thank everyone for participating and being a part of my endeavor for child health. Of course, this channel aims at clearing your concepts and keeping you updated. I am overwhelmed with so much of love, appreciation, and respect, and this is what keeps me going despite sometimes being so very busy on the chair I'm currently at. Thank you for all the motivation. So, starting with maternal HIV infection. So, we can categorize infants delivered to mothers with HIV infection into 2 categories. First, who are at low risk of acquisition of infection, and second, who are at high risk of acquisition. So, infants who are at low risk of acquisition of perinatal HIV are those whose mothers have received ART adequately and regularly during the antenatal period. So, these infants have somewhere around less than 50 copies per ml of HIV DNA near the time of delivery. So, in this case, if the mothers are exclusively breastfeeding these infants, then in that case, at the time of birth, we have to start daily nevirapine therapy. The dose I shall be discussing soon. And this should be continued for a minimum of 6 weeks. In case the infant is being exclusively fed with replacement feeding, for example, this is seen in patients whose mothers have terminal illness or they have died due to some reason, or those who are not breastfeeding their babies despite adequate counseling. So in these patients, daily nevirapine or twice daily azithromycin is commonly known as zerovodine. This is given at birth and this is continued for 4 to 6 weeks. So actually, when we start zerovodine therapy, we need to monitor CBC with differential leukocyte count, since anemia and less commonly neutropenia is seen associated with it. So this is the entire flowchart which is expected for a baby who is delivered at the time of birth and is at low risk of acquisition of perinatal HIV. So what actually are the feeding recommendations for infants who are delivered to these mothers? According to the National AIDS Control Organization guidelines, infants should actually be exclusively breastfed for the first 6 months because the benefits far outweigh the risks, and this should be followed by breastfeeding along with complementary feeding till at least 1 year of age, followed by gradual stoppage of breastfeeding over a month. Mixed feedings should not be given at any cost during the first 6 months of life, and if at all replacement feeding is being given, then the commercial infant milk formula which is chosen should be AFAS. AFAS is a mnemonic which is often asked in your PG Viva also. Here A stands for affordable, F for feasible, A for acceptable, sustainable and safe, and this is as per the 2006 WHO recommendations. Infants at high risk of acquiring perinatal HIV are infants whose mothers have received antiretroviral therapy for less than 4 weeks at the time of delivery, or those whose mothers have high viral load, that is RNA more than 1000 copies per ml within 4 weeks of delivery, or the mother has acquired infection during pregnancy or breastfeeding, or HIV exposure has been identified during delivery or postpartum period in a breastfed baby when the prenatal screen was negative in that mother. So in all these 4 cases, what needs to be done at the time of birth is that we must start daily 12-hourly azithromycin therapy along with 24-hourly nevirapine therapy, which is given for the first 6 weeks of life irrespective of the type of feeding. And this is followed by either azithromycin and nevirapine together or nevirapine alone for an additional of 6 weeks. So a total of 6 plus 6, that is 12 weeks therapy is recommended for infants who are at higher risk of acquiring perinatal HIV. And this is the final flowchart in these infants. What the Avery's textbook of neonatology 24th, which is the latest edition, says that it suggests presumptive HIV therapy to these babies who are at high risk of acquiring perinatal HIV, and this comprises of azithromycin, lamivudine and nevirapine, which should be instituted as soon as possible after delivery, because it not only serves as HIV therapy but it also serves as prophylaxis. So considering the further course of babies who are delivered to these mothers, we perform an HIV-1 DNA PCR at 6 weeks in the dried blood spot specimen, and if it all turns out to be positive, we repeat the same HIV-1 DNA PCR but this time in the whole blood. If again it is positive, we repeat it again for final confirmation, continue cotrimoxazole therapy for prevention of pneumocystis jirovecii infection, start pediatric antiretroviral therapy and continue breastfeeding. Along with this, we finally perform 3 rapid HIV antibody tests at 18 months of age to establish definitive diagnosis of HIV infection in the infant. However, if the initial dried blood spot sample was negative, then in that case or in a case when HIV-1 DNA PCR is negative in the whole blood, then in that case we continue cotrimoxazole therapy and stop nevirapine duration depending upon the risk categorization of the infant. We also repeat HIV-1 DNA PCR at 6 months of age or earlier if the child is symptomatic. We continue cotrimoxazole therapy till HIV is finally excluded and continue breastfeeding till 1 year of age, followed by gradual stoppage over 1 month, and then repeat HIV-1 DNA PCR by dried blood spot at 6 weeks after cessation of breast milk feeding or if the child becomes symptomatic ever, and repeat 3 antibody tests at 18 months of age to establish a definitive diagnosis. So if the initial screen of HIV-1 DNA PCR at 6 weeks of age is positive, then in that case we perform this HIV-1 DNA PCR in the whole blood for confirmation. But if it is negative, then we perform this dried blood spot screening 2 times more. First at 6 months of age or earlier if the child is symptomatic, and second at 6 weeks after stopping the breast milk feeding or if the child becomes symptomatic. We finally confirm HIV infection in either of the 2 scenarios by 3 rapid HIV antibody tests at 18 months of age to establish a definitive diagnosis. Why 18 months of age has been chosen as the cutoff? Because what one must also remember is that if at any point of time the HIV-1 DNA PCR is positive, we need to follow the left-sided algorithm. Why we recommend 18 months of age as the cutoff is that because antibody testing before 18 months of age reflects maternal antibody status, and therefore it will not be conclusive for the infant per se. So what should be the ART dosing? In 0 to 6 weeks of age, depending upon the birth weight and gestational age, the dose of nevirapine is 2 mg per kg OD for babies with birth weight less than 2000 gram, 10 mg OD for birth weight between 2000 to 2499 gram, and 15 mg OD for birth weight more than equal to 2500 gram. And the corresponding doses for azithromycin are 4 mg per kg per dose BD, 10 mg BD and 15 mg BD. From 6 to 12 weeks, nevirapine is given in a dose of 20 mg OD and azithromycin 60 mg 12 hourly. Along with this, cotrimoxazole dosing is again based on weight band. 3 to 5.9 kg or less than 6 months, you give 2.5 ml OD. 6 to 9.9 kg 5 ml OD. 10 to 14.9 kg 7.5 ml OD, and more than equal to 15 kg 10 ml OD. Must remember that syrup cotrimoxazole has 40 mg trimethoprim and 200 mg sulfamethoxazole. And cotrimoxazole prophylaxis is actually recommended in all HIV exposed infants less than 18 months of age, starting at 4 to 6 weeks of age, when there is a risk of the risk of acquisition of pneumocystis jirovecii pneumonia increases, or in breastfeeding children of any age and is continued still HIV infection has been excluded reliably. So what one needs to remember is that mother to child transmission can occur any time during pregnancy or during delivery, which is the most common time of acquisition, or during breastfeeding. Along with this, the risk of perinatal transmission is 15 to 30% in non-breastfeeding populations and 20 to 45%, that is marginal increase, in breastfeeding populations. Vaccination is recommended in all exposed or infected but asymptomatic neonates with all standard vaccines as per the national immunization schedule, and in case of immunosuppressed or symptomatic babies, all standard vaccines are to be given except for live vaccines like BCG, OPV and varicella. The next most commonly encountered situation is maternal hepatitis B infection. Ideally, all pregnant females should be tested for HBsAg prenatally, and in case testing is unknown at the time of birth, the samples should be sent as soon as possible. The risk of vertical transmission of hepatitis B infection if mother is HBsAg positive but HBeAg negative. HBsAg is HBe surface antigen and HBeAg is hepatitis B envelope antigen, which is basically suggestive of infective state of the patient. So if mother is HBsAg positive but HBeAg negative, then in that case the risk of transmission is 5 to 20%, and in case mother is positive for both the antigens, the risk of vertical transmission is 70 to 90% to the infant. Maternal hepatitis B infection per se is not a contraindication to breastfeeding. This you must remember, and that 90% of infected infants become chronic carriers. So a scenario in which the maternal prenatal test is positive for hepatitis B surface antigen, at the time of birth we need to administer two things to the babies: hepatitis B vaccine 0.5 ml, which is 100 international units intramuscular stat, and hepatitis B immunoglobulin 0.5 ml intramuscular. Both need to be administered in different thigh each. The protective efficacy of hepatitis B vaccine per se is 70 to 90%, and of hepatitis B immunoglobulin is 10 to 30%. So in case hepatitis B immunoglobulin is not available, you must give the vaccine alone. Also, the time window for administering hepatitis B immunoglobulin for babies birth weight less than 2 kg is less than 12 hours of birth, and for babies with birth weight more than equal to 2 kg is up to 7 days of birth. But giving the benefit of doubt, we administer the immunoglobulin any time we receive it, as soon as possible. And a complete hepatitis B vaccination should be done to these babies. For babies with birth weight less than 2 kg, 3 more doses, that is at 6, 10 and 14 weeks, should be given as per the schedule. But for babies whose birth weight is more than equal to 2 kg, you can skip one additional dose at 10 or 14 weeks, but you must definitely give 2 more doses. And even if you give 3 doses, it is okay. So birth dose may or may not be counted in these babies. And then final testing is done again at between 9 to 18 months of age, for the same reason that maternal antibodies, they interfere with the correct determination of infection. So at 9 to 18 months of age, you look for anti-HBs antibodies in the baby and hepatitis B surface antigen assay. So in case hepatitis B surface antigen is positive but anti-HBs antibodies are negative, this means that the child has high possibility of positive hepatitis B infection. Whether or not he is infective to others is not known. So you must refer to the child to a pediatric hepatologist and gastroenterologist. And here also I would like to tell you that for starting hepatitis B treatment in a child, 3 factors are looked upon, and these are immune active disease, level of ALT elevation should be more than 2 to 3 times the above limit normal, and measurable hepatitis B DNA values. In case anti-HBs antibodies are positive means they are more than equal to 10 milli-international units per ml, and HBsAg antigen is negative. In that case, the baby is immune and don't need to do any action further. In case, however, if anti-HBs antibodies are negative, that is they are less than 10 milli-international units per ml, and HBsAg antigen is also negative, this implies a suboptimal response to vaccination, the child is neither infected nor is he immune at the same time. So you need to re-immunize the child with hepatitis B vaccine. So finally, talking about a very commonly encountered situation, maternal tuberculosis infection, especially in developing countries like India. Maternal tuberculosis infection poses a risk of congenital tuberculosis in the baby, which has been defined by Cantwell et al. The following set of criteria have been given. The child should have proven tuberculous lesions with at least one of the following four: lesions in the first week of age, primary hepatic complex or caseating hepatic granuloma, tuberculosis infection of placenta or maternal genital tract, and exclusion of postnatal transmission by thorough investigation of close contacts of the baby. Transmission can occur via the hematogenous route from the infected placenta via the umbilical vein, or by in utero aspiration or ingestion of infected amniotic fluid from placenta or endometrium, or ingestion of infected amniotic fluid or secretions from maternal genital lesions during delivery. Most common sites of involvement in a newborn are lungs followed by liver. In these patients, we must first look at maternal infection status at the time of delivery. Now suppose the mother is on ATT, she is diagnosed but not taking ATT, or she is non-compliant with therapy. Then in that case, we must look for clinical evidence of congenital TB. And in case there is no clinical evidence, we perform these investigations: a chest X-ray, a Montauk's test, and 2 specimens of gastric aspirate. And if these are negative, then in that case we give INH prophylaxis for 6 months of duration and simultaneously evaluate for clinical evidence of tuberculosis every 4 to 6 weeks until 6 months of age. If, however, these lab investigations are suggestive of tuberculosis, then in that case we start treatment with anti-tuberculous therapy, the regime being 2-HRZE plus 4-HRE. If on the first hand itself the clinical evidence of congenital tuberculosis is positive, we perform chest X-ray, Montauk's test, 2 specimens of gastric aspirate, and we also perform a lumbar puncture. Even though Avery's 24th edition says that CNS involvement occurs in less than 50% of cases, but we must evaluate because the signs can be non-specific, and if at all they are positive, we must start treatment. The duration, however, will not be 6 months alone. If the maternal infectious status at the time of delivery is such that the mother has completed the course of ATT before delivery of the baby, then in that case we must again look for clinical evidence of congenital TB, and most likely there is no positive evidence of congenital TB, and then we follow up the patient and we evaluate for clinical evidence of tuberculosis every 4 to 6 weeks until 6 months of age, and if at any time comes out to be positive or suggestive, then we start treatment with anti-tuberculous therapy, and in case it does not come out to be positive at any time, then in that case we don't need to perform any action. A few nuggets we must know: that separation of the mother-infant diet is essential in these patients only when the mother is considered to be infectious at the time of delivery, because she can transmit the infection from respiratory route to the baby, she is non-adherent to medication, has drug-resistant tuberculosis, or mother has not been on at least 2 weeks of anti-tuberculous therapy. Breastfeeding is again not contraindicated as in hepatitis B infection because breast milk does not contain tubercle bacilli. But in case mother is infected, expressed breast milk should ideally be fed to the baby to prevent the risk of transmission directly from the respiratory route. Neonates likely have a higher concentration of bacilli in their sputum compared with older children, and this is one of the startling facts to me also. While I was reading Avery's 24th edition, I found this, that neonates have a slightly higher concentration of bacilli in their sputum, and they are more likely to have AFB positive smear on tracheal aspirates and other specimens. And other healthcare workers and hospitalized newborns can also get transmitted from these infected neonates, most likely due to aerosolization of infected sputum during respiratory manipulations, for example during intubation. So summarizing it finally, in babies with maternal HIV infection, we at the time of birth need to give nevirapine plus minus zidovudine therapy for 6 weeks, and according to risk stratification we might have to extend the duration to 6 more weeks, that is 12 weeks total if the baby is at high risk. Later on we perform 3 rapid antibody tests at 18 months of age to make a definitive diagnosis, but in no case mixed feeding should be administered. However, breastfeeding is the recommendation of choice. In babies with maternal hepatitis B infection at the time of birth, we need to give anti-hepatitis B vaccine and hepatitis B immunoglobulin. Later on, HBsAg antigen and anti-HBs antibodies are performed at 9 to 18 months, and depending upon the value, we proceed further. Breastfeeding is not contraindicated in patients with maternal hepatitis B infection. And babies with maternal tuberculosis infection at the time of birth, we look for clinical evidence of tuberculosis and work up according to the clinical positivity or negativity of the clinical evidence, lab evidence, and the maternal infectious status at the time of birth. Later on, we look for clinical evidence of tuberculosis in the baby every 4 to 6 weeks till 6 months of age. And once again, breastfeeding is not at all contraindicated in these babies. So I guess this video has been of great help to you, and it shall prove to be beneficial to you regarding your own clinical practice while attending the resuscitation calls, as well as for your examinations, especially your PG and exit examinations. Thank you so very much for a patient listening and watching, and I'd be glad if you guide me to as on what specific topics you want more videos. Thanks again.